Ladies and gentlemen, welcome to the 2015 VNAA opening keynote. Community partnerships with non-traditional providers working together to drive population health. Please welcome Mary DeVoe, Chair of VNAA's Board of Directors and President and CEO of the Concord Regional Visiting Nurses Association in Concord, New Hampshire.
Thank you very much, and good morning. I'm so excited to be here and to welcome you all to our 33rd annual meeting here in New Orleans. I've had the distinct honor of serving as chair of the VNAA board for the last 2 years, and it has been a very humbling experience to meet many colleagues around the country who have done some outstanding practices for home health and hospice. So this annual event will allow us to gather as a community and to celebrate the important work of the mission-driven home care and hospice providers across the country. We come together to share our ideas and strategies, to network with our peers, and to bring home information that will advance our work. One of the gems of VNAA truly is the networking that we all do, not just when we come to our meetings, but also throughout the year. Before I turn the stage over, I'd like to acknowledge our sponsors and exhibitors. Our sponsors are the true partners of VNAA, and their financial support is key to the success of our annual meeting. Without their support, we would not be able to hold this meeting. So I really encourage you to make sure you thank them when you see them and ensure that we can help them, they can help us to improve our mission to continue to serve the communities. I also want to make sure you go to the exhibit hall today, because spending time talking to them, they have a lot of tools, products, support that can help us become stronger organizations in our own communities. So over this past year, it's been a great working with the organization, with the staff to accomplish much on behalf of the not-for-profits. The body of work that the VNAA staff have been doing has not done yet. We really want to thank one committee this past year, the annual meeting planning committee, who has done an outstanding job selecting educational programs for this event to meet all our members. The committee began planning last summer and received numerous abstracts. This group has worked hard on the educational breakout and posters that you will see over the next 2 days. I hope that we can get to thank the annual meeting committee. If you see them, please thank them. There will be a breakout session. There are 4 tracks this year, and a fifth one has been added, a cross-cutting IT track to help offer support for IT innovation. Other ways to help is the 2 keynote speech sessions that will be held for healthcare thought leaders who will encourage you to broadly think about your role in advancing home health and hospice. Another group of dedicated individuals I want to thank are my colleagues on the board of directors. They have been so supportive and care deeply about the members and the communities that we serve. And I really want to thank them for all their support and their leadership for this outstanding organization, the Visiting Nurse Association of America. And now I'd like to welcome Tracy Moorhead, our president and CEO.
Good morning, everyone. Oh, now come on. I know that you had a late night last night, but we are in lovely New Orleans. You can do better than that. Good morning, everyone.
Good morning.
Thank you. I want to welcome our panelists up, and I'm going to kind of set the stage here, and then I'm going to get out of their way and let the experts share with you some thoughts and perspectives that I think will be a great way to set off this year's conference. Those of us who joined us last year in Las Vegas know that we spent a lot of time there talking about partnerships and how to develop partnerships with other providers in your community. We specifically focused on accountable care organization models and patient-centered medical home models and other health system partnerships. This year, we're putting you in the driver's seat, and we're talking about your role in driving population health improvement in your communities. This is a critical opportunity and a critical time in our industry's evolution. And we want to make sure that you have the power and the tools in your hands to look at your organizations and your industries, your agencies, I should say, and really begin to move forward, to reassert your place at the table and to drive population health in your communities. I'm really excited to kick off today with this panel on disruption. Healthcare as a whole, healthcare delivery, is going through a cataclysmic phase, and there is disruption happening at every level of healthcare delivery. We've got 3 fantastic speakers here today to talk to you about disruption in their own segments of the industry, and I'm very excited for them to share with you their thoughts and perspectives. The rest of the conference is also going to focus on new tools, new program models, and new opportunities for your agencies to lead population health, care coordination, and quality outcomes in your communities. So let me introduce our expert panel, get out of their way, and let them talk with you. First up is my friend Cece Connolly. Cece was an investigative reporter at the Washington Post for many years. Cece has translated that skill of telling a story into her role as a leader at PricewaterhouseCoopers in Washington, D.C. at the Health Research Institute, where she now looks closely at trends and opportunities in healthcare. She's going to talk with you today about the role of consumerism in healthcare and how consumer-directed care is really changing the way we are delivering care and interacting with our patients and their family caregivers. Nancy Gagliano is a physician who's the chief medical officer with CVS MinuteClinic. Can you think of anything more disruptive to the physician delivery model than the CVS MinuteClinic? She's going to talk with you about how CVS MinuteClinic is working in communities to better coordinate care for patients and support physicians. And finally, Dr. Mark Blatt, also a physician, who was in family practice for years, went back to get his MBA, and is now leading is a thought leader in our industry on the role of nurses and how technology can support and improve not only their workflow, but again, patient outcomes and patient satisfaction. With that, I want to turn it over to these esteemed experts in their various fields. They've got some incredible stories and perspectives to share with you. They're going to have a conversation with each other, and then we're going to have some time at the end for some Q&A from the audience. So please be thinking of your questions, be thinking of provocative opportunities for your agency to lead disruption and improve care delivery in your communities. Thank you again for joining us, and I'm going to turn it over to Cece.
Wonderful. First of all, a big thank you to Mary and Tracy and all of you for joining us this morning. I know it's especially early when you come to New Orleans and you have to be in your seats by 8 a.m., so thank you. As Tracy mentioned, we have been asked to come and disrupt a little bit. So we are intentionally going to be provocative, or as my friend Donna Brazil likes to say, and Donna, of course, grew up in Kenner, Louisiana, just literally on the other side of the train tracks from here. I'm intending to stir the pot a little. And we are hoping to get some reaction from you and a little bit of a rise, perhaps. But I hope also that by the end of this dialogue, maybe you have just a couple of different, fresh ideas to take back to your organizations and to at least give some thought to in this new health economy, as we refer to this transformation period. Where are you going to fit in, and where are the opportunities? Because this is a season of opportunity in healthcare. It is not the time for the defensive crouch. It is the time to go out and seize opportunities. And you want them to be smart opportunities that you take, but they are there for the taking. And so the first thing that the three of us decided we were going to do was open with a provocative statement, intentionally, an assertion that we're going to each put out on the table, talk a little bit ourselves, and hopefully engage you in the conversation as well. So here's mine. It's a little bit of a mouthful, but to open, I would like to assert to you that digital savvy home health is the linchpin of new care models designed to meet consumer needs. And let me tell you, although that's a mouthful, those words are chosen intentionally. There is a reason why I say designed to meet consumer needs. Now, I know that you all are accustomed to taking care of patients. And understandably, there's a very important relationship between patients and their clinicians. Some would suggest it's even sacred. And I don't mean to detract from that relationship, but let's face it, nobody really wants to be a patient. But everyone is a healthcare consumer. Each and every one of us today in our own lives, forget about your businesses, just in our own lives, we are making decisions relating to what healthcare services we're going to purchase, from whom, at what price point, whether you're shopping for an insurance on an exchange, or maybe you're enrolling in Medicaid, or you're trying to sign up a family member, or maybe you're in a high deductible health plan and you have to make decisions about what's going to come out of your own pocket. People in this country today are, in fact, shopping for health care. They are consumers. And they bring the same consumer attitudes to your industry that they take now when they shop online at Amazon, when they order up an Uber car to come and retrieve them anywhere on the planet immediately. They bring all of those same expectations now to healthcare. Digital savvy, important that I mention that as well, because it is no longer sufficient in healthcare today to just be good at medicine or to be a wonderful, compassionate caregiver. Those are still critically important. But we live in a digital era, and you have to be digitally savvy in your business in order to bring the highest quality care to your customers. So it's very important. And of course, new care models. We're going to hear a lot about that from the two doctors on the panel as well. But as you know from your own experiences, those are changing as well. So let's dive in. Much of the work that we do at our PwC Health Research Institute is, in fact, understanding consumers. We do this through a lot of survey work, focus groups, etc. So one of the things that we did not long ago was we asked 1,000 US consumers, adults, and then also 1,000 clinicians, primarily physicians, but also healthcare extenders, nurse practitioners, physician assistants, etc., a series of questions around whether or not you would be comfortable using results from do-it-yourself options. Now, all of these options, as you probably are aware, are already on the market or poised to come on the market. So as you look down this list, if you can't read them all, for instance, the first one is use an at-home strep test. Now, I can tell you I happen to be visiting an aunt and uncle up in Massachusetts this weekend. He had been in bed since Wednesday. He had a terrible sore throat. He had a fever, you know, kind of that lump in the throat. And Thursday, Friday, Saturday, Sunday goes by, and he's still in bed. Why? Because he's stubborn and he doesn't want to go to a doctor. But what do you think the chances are that he probably had strep with a fever, right? Now, if he could have done the swab, drop it in the overnight express and get the results, he probably could have been on a prescription by Thursday or Friday. Nancy can probably tell me better how quickly they could have gotten that prescription to him. So things like an at-home strep test, checking vital signs, sending the photo of a rash. I often say that maybe it's not the people in this audience, but maybe your children are in fact posting images on Facebook today and crowdsourcing certain diagnoses. So this is not a foreign concept. So as you go on down this list of do-it-yourself health options that are out there now, you see that on the left-hand side, the consumers are leading the clinicians in every single category. Consumers are more ready, willing, and able to embrace these, except for one, the bottom one. And again, if you can't read it, it is do a urinalysis test at home with device on phone. Now, this is not a scientific answer, but I have a theory on that one, which is when average consumers read that, they had the image of peeing on their phone, and they said, ick, no thank you, that is just too far for me. I'm willing to take a picture of my rash, but I'm not gonna do that. Whereas the clinicians were okay with it. But in every other area, I think this message comes through very clearly, just scanning down that list. Consumers are driving the change in healthcare today. And they're going to continue to push on it. So another thing, We, again, in part of our survey work, have learned that about half of the physicians and extenders that we surveyed told us that e-visits could replace 1 in 10 encounters. Now, that may not sound like much, but it's actually a pretty significant shift in the way that care is delivered. If any of you are familiar with Kaiser Permanente, they are up to about 1/3 e-visits currently across their entire health system. So that means email, telemedicine, et cetera, very significant numbers. Similarly, over on the other side, we have about half of the consumers today that are telling us that, first of all, they're very eager to communicate with their caregivers online. They want that email capability. They want the lab results that come directly to their cell phone immediately. They don't have to sit and wait. And they're also very eager to pay for medical care online in the same way. You know, I often say, if you want to think about the change coming to the healthcare industry, think about how the banking industry in this country used to work. So I remember the days when I would get my paycheck on a Friday, and I would race over to the Bank of America 2 blocks from my office so that I could get to a teller, deposit my paycheck, and get my spending money or my PIN for the weekend, right? Everybody kind of remember that? I can remember my father counting out bills to give my mother her grocery money to go shopping. And one week, my brother thought it would be really cool to count that much money, and he put it in his pocket and went to school, but that's another story. But that's how we used to handle money and financial transactions in this country. What do we do now? We're in our hotel room at the Roosevelt Hotel. We're on our iPad. We have to pay a bill. We push 2 buttons. The bill gets paid. We never worry about that. My husband doesn't even carry cash any longer. He sees no need for it. You can transfer money from an account here to an account in a foreign country. That is what is coming to healthcare. And importantly, I wanted to show you here that this middle line, the connector, the logical connector in many of these transactions in healthcare are, in fact, home health employees. You have the potential to serve this vital role as the connective tissue in so many of the different players that are now emerging in healthcare, whether they're the ones that you're already familiar with, physicians, hospitals, long-term care facilities, that you're already doing some connecting, but maybe you're doing that connecting in person or telephone or by paper as opposed to digitally, and also connecting in the same way with those consumers. So this gives you an opportunity to really extend and expand your role as connectors in that case, but to do it in potentially not only a more efficient way, but frankly, a way that your consumers would like you to operate if you're not already. So another thing that we've looked at is the question of how willing providers are to tap home health to manage chronically ill patients. So the first snapshot I want to show you are traditional fee-for-service caregivers. And you can see here it's about a total of 60% when we ask them, do you now rely on home health caregivers to help with your chronic patients? You know, about 32% say they already do that. Another 26% are considering it. So that's a good, healthy 60%, not bad, right? What about when we ask providers that are already in risk-bearing arrangements? So not necessarily traditional fee-for-service medicine, but they've gone to some financial risk circumstance. The number climbs to 80%. So what that tells you, and again, in my stirring the pot theme, I should have said at the beginning that I am basing my comments on the fact that fee-for-service medicine is on the road to death. It is terminally ill. I don't know if I can say that any more clearly, but we feel very strongly at PwC and at our Health Research Institute that the future of healthcare is not fee-for-service medicine. So if it is not fee-for-service medicine, and you need to think about positioning yourself for the future, you want to start to identify and relate to and work with these providers that are already beginning to take risk, because they're in the vanguard of the new movement. And what we've just heard from them is that they, in larger numbers than the traditional fee-for-service providers that you work with, are very eager to work with you and to partner with you. So I think that's a pretty encouraging data point from you. Now, the other thing that we've asked is, where are the opportunities for home health to fill gaps? So you know that data has become so critically important in healthcare, and data sharing is really the key to it all. If any of you were following some of the discussions at HIMSS last week, you know that so much of the focus was on interoperability, data sharing capabilities. So we frequently ask lots of different stakeholders in the healthcare world, what sort of data sharing are you doing? Who are you now sharing data with? And not surprisingly, kind of up at the top of the list in the high 57% range, they say that they share data within their own practice. Okay, well that's good, that's important, I'm sure. You come down the list a little ways and fewer of them say, I might share some data with the insurers, maybe the pharmacy, et cetera. We ask, how many of you are sharing data with the home health sector? Just 15%. Now, this is where we get to find out if you're kind of a glass half full or a glass half empty kind of person, right? Because 15% doesn't sound so great right now, to be honest with you. But when I look at that 15%, and the reason that I really wanted to draw it out for you here on this slide is to say, that's your big opportunity. That is a huge untapped area of opportunity for you. If you find these ways to share data more with the providers and with the patients or consumers, you are going to be so far ahead of not only your competition, but so many other players in the healthcare world. And I'm not going to steal Nancy's thunder, but I think that there's a very good example with what CVS is doing in terms of data sharing. And that should give you some ideas around the types of partnerships. As you move more into population health, you know that the data and analytics will be so critically important, and the sharing of that, because without it, you simply don't know what you have on your hands. You don't know what you're dealing with. You can no longer kind of chart it out with pencil and graph paper and figure out what exactly you're working with. So that to me says there's an area to jump in and really tackle these notions around data sharing. Just a couple of other quick thoughts here in my closing minute or two. As you have, if you haven't had a chance to walk through yet next door, which I did this morning with my cup of tea, it's amazing the tools and technologies that are now coming onto the market so rapidly. We did a little study for the 5-year anniversary of the ACA, and we determined that there were about 100 new companies that have been formed specifically as a result of the Affordable Care Act. And many, many, many of those new companies that are forming, often with a great deal of venture capital money, because venture capital sees the opportunities in healthcare. Many of them are, in fact, technology-oriented. Many, many of them are consumer-oriented, or both. And so, as you're aware, over on the right-hand side, any number of consumer tools, sometimes I like to just get a picture of a few of my favorites that you can see there. And so in the center, does anybody know what that thing in the center is, the white on the right? So it's got a great name. It's called Otto, after otoscope. And that's an attachment on that cell phone made by a company named CellScope. It's on the market today, FDA approved, selling for, I think, about $199. So just think back to the miserable winter that we just went through. Your kid has the third earache of the winter. You don't want to drag you and your child into that doctor's office where all of those other sick kids are coughing on you as well, when you know darn well it's the third ear infection of the winter. So you whip out your cell phone and you put on your little Otto and you take a picture of Johnny and you push the button on your cell phone and the picture goes off, and yes, indeed, you were right. Johnny's got his third ear infection of the winter, and bingo, the prescription for Johnny is sent to CVS, which delivers it to your house right away, or whomever. When I speak to lay audiences and say, would you like that? They're just about jumping out of their seats, especially after a winter like this. They are desperate for those sorts of things. So that's Otto, my favorite. Of course, the Apple Watch is getting a lot of attention. The other is a pill bottle that can record when it's opened, which, as many of you know, medication adherence, big, big challenge. So really, this is just to let you know there are so many of those tools. In terms of the home health industry, you all are the experts, not me, but of course you have Home RN, in which you can add photos, video, et cetera, to a patient record. Very, very useful in terms of the data sharing that we just talked about. Also, Healthcare Synergy has a toolkit for home health, which enables you to do a lot of searching, ICD-9, soon ICD-10 codes that you can search, a wonderful library and archive. So there are, in fact, many tools, many of them you'll see on display next door, that can help you make this transition. And so with that, I hope I have at least given you a little bit of food for thought, and I think we have a couple of minutes to chat.
I have a question for you. Most of us in the audience and here are healthcare providers. And I know we all feel that that human connection is very important. And I was very intrigued by the fact that you said consumer or patient. Who are they? How do you see the world evolving where we don't lose the human touch, but maybe we augment it with the digital approach? Could you?
It's an excellent question, and I certainly hear it, especially from clinicians that have spent so much of their careers developing those relationships. And that's not just doctors, but it's so many of you in the audience that have gotten to know your patients over time, and you understand their quirks and all of that sort of thing. I don't think that's ever going to disappear, because that is so valuable, especially when you're trying to get to an important diagnosis. But what we're increasingly hearing from consumers is that they prefer to choose more of the where and the when and the how. So that if it's just the flu shot, they really don't care if they see Dr. Smith, who they've been going to. I mean, I'll now get a flu shot just about any place, except maybe a gas station, right? Maybe I'm taking it a little too far. Doctors are going to stop me. But when you think about that, where we used to have to go and get a flu shot, and now airports, I've been to healthcare conferences where they're giving them out for free, right? So the same with the ear infection. Parents feel they can make that quick call on their own. They save the doctor visit when they feel that it's a little more complicated, it's clearly out of their realm. The other important thing is that all clinicians and caregivers are shifting, I believe, and I'd love to hear both of your thoughts on this, but certainly our impression is that they are kind of moving up the food chain so that they're serving as more of the care quarterback, if you will, and they're the brains of your care team. So you want the doctor and the other clinicians to be using their brain power thinking about the more complex things than spending the time doing the strep swab or whatever it is. So I think it's everybody kind of moving up in sophistication, which is a wonderful thing as we get into genomics, which I know, Intel is very involved in, more personalized medicine, and also thinking about that population health. So again, the patients with the multiple chronic conditions that need to have those ongoing relationships and conversations to really manage the complexity that's out there and looking at a population. At least that's my read on it.
Talking about consumers and using home consumer tools to do tasks that often were traditionally done through some professional or intermediary. As more of these tools become available, as more information sharing becomes available, what percentage of the routine visits that these guys do into the home environment are going to become e-visits? And how fast? I think it's going to go only at that 10% level. You mentioned Kaiser up to a third. In some cases, I know half of their visits are up to e-visits, half, and they're the largest HMO. They got a rational reason to do it. What happens to wound care? What happens to a lot of what home visits for visiting nurses, skilled nursing is about? Does that go away? Does that change?
I think that it definitely heads more in the direction of a third, Mark. I certainly do. It's a little bit harder to forecast how quickly, and I think some of that is going to depend, frankly, on regional differences in the country. We know that there are certain places that we travel in the U.S., California, because of Kaiser's big presence, for instance. I see a lot in Minnesota, Wisconsin, where they've always kind of been a little bit on the front edge in terms of using different technologies. So there are a couple of places like that that just tend to be more of the innovators. The other places where we're going to see it are rural areas, where just plain and simple, there's demand for healthcare services, not enough caregivers, so they're going to turn to technology to deal with some of that squeeze, so you don't have to travel so far all the time to have a clinician. And also where there are real financial pressures. Because again, what consumers keep saying to us is, I'm spending more of my own money on my care, and if it's my money, you know, I'm going to be careful with how I spend it, and I certainly want the convenience. It's interesting because I think that probably much of your customers may be older if they're at home receiving care. Or have certain disabilities, and some of the research that we've done looking at these target audiences, dual eligibles, for instance, we thought, we had sort of a hypothesis that dual eligibles would not be as eager to embrace technology options like apps and doing things on your cell phone or online. Lo and behold, when we did a survey and segmented out a duals population to look at them separately, a real aha moment for us, which was that they were more interested than the base population. And so again, when we see a finding like that, we go and we do some interviews. And what we discovered was that in many instances, and I bet you all just know this because of your own personal experience, but an aha to me, was that many of those individuals, they have a whole bundle of problems, right? I know that's not a technical medical term.
It works.
But they may not have a car to get to see a doctor or a nurse. They may have behavioral or mental health issues in which they're not super comfortable walking into a public building that says mental health office, you know, because of some stigma associated with it. Or they may just not even be that comfortable out in society necessarily, depending on what their series of illnesses might be, or they may not be super mobile. And so for all of them to be able to say, look, what if we could give it to you in your tablet or on your cell phone? You could communicate with someone, an expert or your person via remotely. They're very excited about that possibility. So I think that we also have to be willing to be open to knocking down some of what we thought we've learned in the past, because it is such a dynamic situation out there. And again, consumers are embracing this change faster than many of us. And that's very difficult because you also are kind of you're the quality assurance people in this system, right? If we just let consumers kind of run around and diagnose themselves, we'd probably be in a world of hurt. So they rely on you for your expertise and your knowledge and your experience. They're simply saying they want it to be more convenient, more accessible, more suited toward them, I think.
Good approach.
Thank you.
Excellent. Nancy.
So I'm up. So thank you all for being here today, and I'm thrilled to be here. I'd like to start out by just telling a little bit of a story as to how in the world somebody who'd spent 20, 25 years at Massachusetts General Hospital ended up shifting to Minute Clinic and working for CVS. So I'm an internist, a PCP by training, and spent lots of years taking care of patients and working as an administrator at Mass General. I went through capitation in Massachusetts that came and went and was really a disaster, but very, very challenging. And I was actually a really good doctor. I got a top doc award in 2002. Very proud of myself. I took care of high blood pressure and diabetes and all that stuff. I was really good at diagnosing people. And then I realized that I really was annoyed when I got those lists of people who had conditions and they never came to see me. And I was really good at taking care of my good doobie patients, the patients who came to see me. And I actually didn't think very highly of the patients who didn't bother to come see me. Why was that my problem? And then I had an epiphany. It's not all about me. It's not all about Mass General. We do great things, but you know what? We're really good for a small segment of the population. And there's a bunch of people out there who don't like doctors, who, if they have to take time off from work to drive to Mass General, to come to my office and see me and their hourly paid employees, it costs them a boatload of money to come see me. So guess what? They don't. So that's when I had my epiphany, and I said, you know what? There's plenty of doctors who are doing a really good job in very standardized traditional health care, but we're not solving very much because we're not making good health care accessible to people. And therefore, the opportunity to start working at Minute Clinic at CVS was transformational for me. To be able to provide high quality, low cost, accessible health care right in people's community, open in the evening, open on weekend when it's convenient for people, really makes sense. We're not trying to take over the world. We're not trying to do complex diagnosis, but those earaches, let me tell you, I'm a parent, thankfully my kids are older now, but it seemed like every Friday afternoon I'd get home from work and the temperature would be 103. I was like, why doesn't this happen during the week? It only happens on Friday afternoons, Friday evenings at 6 o'clock. And it would always be an earache. And it would always be an ear infection. And there went the rest of the weekend. So let me tell you, hopefully most of you are aware about Minute Clinic, but let me tell you a little bit of the highlights. We are the largest healthcare retail provider in the country. When I got there, we had 400 clinics. We now have 1,000 clinics. We're going to have a big celebration this summer when we open our 1,000th clinic. We're open evenings and weekends. 50% of the time that patients come to us is evenings and weekends. 50% of the patients who come to us do not have a primary care provider. Despite the fact that there's lots of insurance, and even in Massachusetts, which has had universal health care coverage for quite a few years, we still see the people who don't have insurance. We practice evidence-based medicine, which means if you have a sore throat, we follow the science. And we only give you an antibiotic if your rapid strep is positive. And if it's negative, we send it away to confirm. And if you go see us in Louisiana, or if you go to California, you get the same exact standard of care. And we watch it very, very carefully. 10% of all of our visits have a chart review done within 24 hours. That review, if there's a problem, gets sent back to the provider so they learn right away. We take all of that information. So we see about 14,000 people a day. All of that information is brought to our quality committee, so if we see trends nationally, we can do very clear education, or if we see trends and we need to take a look at our guideline, we can do that. We use one electronic medical record across the country. So if you're seen in California at Disneyland for measles, we can tell your doc in New Jersey. And we have over 50 affiliates across the country. And I'm going to talk about that in a minute. All of our providers are board certified nurse practitioners or physician's assistants. Guess what? We've done tons of studies. Number one, patients know when they're sick enough to see somebody at MinuteClinic versus the emergency room. You know, traditionally, physicians have been very, very paternalistic and have said, you know, well, they're not going to know. They have to come to see me or they have to be in the emergency room. No, people know. I have an earache. An earache is an earache. I have a urinary tract infection. I know when a MinuteClinic is appropriate. Now, every once in a while, we had somebody literally who came in with a nail gun shot through his hand and said, could you just pull it out for me? Like, no, we don't do that at MinuteClinic. We don't do appendectomies at MinuteClinic. We don't do heart attacks at MinuteClinic. So people know how to use MinuteClinic and they appreciate it. Our patient satisfaction is off the charts. Our satisfaction rate is about 95%. We use Press Ganey. And if you know what a Net Promoter Score is, a Net Promoter Score takes the highest, those who would say, I would refer a friend, and subtracts those who say they wouldn't refer a friend, and come up with a score. Our score is about an 84. That compares with Apple and Trader Joe. Typical physician office is about 60. So we created a low-cost, high-quality healthcare system that patients love, and it is possible. The other thing, now this gets into, we have to evolve too. MinuteClinic can't just start MinuteClinic and be successful and then stop. The world is changing. So we started with earache, sore throats, those kinds of things. And then we said, what does the community need? What are the needs of the community? What are the needs of the healthcare system? What are things that could help the healthcare system? We're not all about competing. We're about providing services that are needed and valued. So we've gotten into the preventative world. So we do a lot of biometric screenings and vaccinations. The Bank of America has hired MinuteClinic to be available to do biometric screenings for all of their employees across the country. What a concept. If Bank of America wanted to do biometric screenings 5 years ago, they would have to send their patients to their PCPs and hope that their PCP, number one, did exactly the test they wanted, and number two, sent them the results. We can do exactly the same test, blood pressure, weight, height, cholesterol, blood sugar, send it to the patient. Right then and there, we do point of care testing. So right then and there, we can tell somebody your blood pressure is high, so are your cholesterol. You need to take care of this right away and send it to Bank of America. We do chronic care monitoring. So we're not about being the PCP for the patient, but if you have high blood pressure and your doc starts you on your medicine, what are the chances that you will show up 3 months later when the doc says, come on back for a blood pressure check? I can tell you, not very high. And as a physician, what did I do? Hope they would come in sometime. And a year would go by and they'd stop their meds and their blood pressure would be high and we'd start all over again. Well, here, you can go to MinuteClinic after work, get your blood pressure checked. We'd say, great job, your blood pressure's good, keep on your medicine, or not so good. Wellness. As a physician, I don't think I ever got anybody to lose a pound. I wasn't trained in behavior modification. Notification, that's a